All right, you are ready to go whenever.
All right, you can all see the screen, okay? Excellent. So I am Rachel Mitchell. I'm a pharmacist here at the specialty pharmacy at W Medicine here at the hub. And there was a request to go over some side effects and things with the direct acting antivirals. So I'm going to do that today. Um, I don't know that this will take the full time for the talk, but I'm hoping that this will give us a chance to talk about drug like side effects, adverse effects, things that you guys see. A lot of times you're presenting cases on the front side of treatment, and we've talked a lot about how we can get some follow-up stuff and see what happens after a patient is treated. So I'd like to take some time also today after we go through some of these things, some of the common side effects, to look at what are you guys seeing in real life? What are the things that are popping up for your patients? What are you doing about it? What are your recommendations? Just to kind of have more of a discussion if you have any of those questions or things that you've seen you want to talk about. But we'll go through some of the common stuff and some of the warnings and things with each of these agents. And the good news is, and the reason that this presentation is pretty short, is that they're generally well tolerated. So most patients don't have a lot of side effects that they notice. And if they do have them, usually they're limited to the first part of treatment and then they get better. And by the time, you get to the second week, a lot of patients are telling me that they don't even notice that they're taking it. And if they do have side effects that continue on, usually because the medications don't stay in the system very long, they have pretty short half-lives, you expect to see that they completely resolve at the completion of treatment. But there are some that are considered class effects, so that's what I'm going to start with. And a lot of them we've covered just in general because a lot of it is just the screening and the monitoring that you do with some of these patients. The first being reactivation of hepatitis B. So we don't just do those Hep B titers when we're treating these patients because we need to see if they're vaccinated to vaccinate them for the insurance prior authorizations, but also because of the black box warning. So we got this after some of the direct acting antivirals were approved. The FDA made this announcement in about 2016, and the reason for this announcement was that there were about 24 cases that had been reported to the FDA of patients that had reactivation of hepatitis B, including 2 fatalities and 1 person that ended up having to have a liver transplant. And this was in a short period of time of the reporting piece. It was like July. I think it was in like the fall of 2013, right somewhere right around when Harvoni was originally approved, to 2016 in July when they put this announcement out. So this is something that we're always doing those tests for, trying to see if patients have a co-infection, and then if they do, treat them appropriately or do the appropriate monitoring. The next is hypoglycemia. So Dr. Gilfus has done a much better job than I'm going to do as far as explaining the background, but we do know that there is a correlation between patients that have hepatitis C and the potential to develop type 2 diabetes. So there have been several studies that have looked at this retrospectively, looked at the data. I have 3 different references on the slide here, but there are more than that that have shown that once patients are treated with DAAs, that they achieve SVR and they have an improvement in their glycemic control. So our concern from a side effect standpoint is these patients having hypoglycemic episodes while they're taking these agents and even after. So there is recommendation for these patients to not only do additional monitoring while they're taking the DAA, but even after they're done, as they potentially have better glycemic control and glucose management as far as their liver goes. So in some of these studies, some of the things that we have seen is that if they're worse off, if they have out of control or really high A1C, they're the ones that have the greatest improvement in glycemic control. So those are the ones that I usually target and try to educate and make sure that they're checking their glucose and they know the signs and symptoms of hypoglycemia. Those that are taking insulin, we did also have seen a trend where they have reduced insulin requirements, where either they have to take less insulin or they're able to come off of it completely. And I always like to point out that these are actually the patients, at least in these couple of studies, the ones we've noticed this with are the patients that are already well controlled. So kind of different than that first group. They're taking insulin, but their A1C is in a good place. But they're the ones that we're noticing we can start sort of taper back on their insulin doses. And there have been a small amount of patients, and I don't think this has been statistically significant in these studies, but there is a trend that patients that are on oral hypoglycemic agents are able to either titrate down on those or come off of them completely. So bringing that to your attention, because it is a class effect, it's all the DAAs. So if they have type 2 diabetes and they fall into these groups, there is a chance that they're going to see those hypoglycemic episodes. So hoping that they know those signs and symptoms, have extra glucose on hand or something that they can take to mitigate that if their blood sugar does go low. And then the last class effect that I have here is decompensation. This is another FDA alert that they put out and is specific to Mavyret, Zepatier, and Vosevi, and that's because they contain protease inhibitors. So we saw reports, again, of FDA reports of patients that had liver failure in the setting of they already had really bad liver function and decompensated cirrhosis. So those are our Child-Pugh B and Cs. So the recommendation is that we don't treat patients with Mavyret, Zepatier, or Vosevi because of this warning. And this came out in 2019, where we had 63 reports of worsening liver function, with some actual fatalities and requirements of transplant. So usually when this happens, we're going to see it in the first fill of their hepatitis C medication with the Vosevi, the Zepatier, or the Mavyret. It happens pretty quickly. So right now, the recommendation for these and the package insert, because of this alert, is that we don't use these agents in patients that are decompensated. All right, and now I've kind of got charts here of the 4 common agents that we use. First up is Mavyret. So what you can see here on the slide is that they're pretty well tolerated. So the most common things are the headache, fatigue, and nausea that we see. And I've got some sort of run-of-the-mill, they're not great. Well, they're not unique, I should say, recommendations as far as how patients can tackle these and mitigate these side effects. But the good news is that they're effective. So any OTC analgesics, from Tylenol to ibuprofen, depending on their other comorbid, which ones that they can take. So those are okay as far as these drugs are concerned, as far as Mavyret is concerned. And most patients, I usually say, what do you usually take for a headache? And if there's no contraindications to that, usually it works if they have a headache in this instance. Some patients will say that they feel fatigued, so taking short naps, making sure they stay active, have a good balanced diet, sometimes taking vitamins. Those are the sort of things that you can tell them to help with that fatigue. The nausea on here, usually with Mavyret from an adult standpoint, is not associated with vomiting. And some of the things, the tips and tricks that I've worked with some patients that have seemed to work is to adjust their meals, whether that be the size of their meal or their content. So remember, Mavyret has to be taken with food, but there's no rules on the types of food or amount of calories per the package insert, just that there's some food to help with the absorption. So a lot of times I'll ask them, well, what are you taking the Mavyret with? And if it's a light meal, okay, take it with something heavier, more substantial, a full meal with more calories, see if that helps a little bit. So you can make those adjustments from the meal standpoint. They can take ginger. I have some patients that have had success with ginger chews and ginger supplements, or they can move up to prescription medications like ondansetron if these other things are not working. But the vomiting that happens is particularly in children. And although there's not evidence behind it, my suspicion is it has to do with the pellet formulation. And I know on this call, a lot of us aren't treating pediatric patients, but the pellets are specifically for the peds patients. So they put them into like the little pellets are almost like like the Nerds candies. So they're about that size. They can mix them with food, or they can do the cheek method where they try to just cheek it and swallow it real quickly, but it's easier to swallow than the full-size tablets, but they taste awful. The number of children that have not done well with those pellets, I would say I have more success with tablets in children than I do with the pellets. So I wouldn't be surprised if the vomiting that's associated with Mavyret in children is just because the pellets taste absolutely awful. So other things as far as the rare stuff that I like to point out, pruritus or itching is something that I have seen in a handful of patients. It is not associated with any specific rash, redness, not hives, but patients just get this diffuse itching all over their body. It is tied more to patients that have liver impairment or severe renal impairment. That number actually, that percentage that's listed here, the 6%, if you look at the data in the MAVERIT studies for renal patients, that jumps up to about 17%. I'm not sure the full mechanism of action with this. I've not seen any great reviews or studies, so if somebody has, please let me know. But probably something to do with cholestasis and bile buildup. So that's why you see, as far as the recommendations on here, you've got your run-of-the-mill cold bath, use really good moisturizer, calamine lotion, and then you can try high-dose diphenhydramine over the counter. And if that doesn't work, escalate to hydroxyzine or cholestyramine. So again, we've seen success with the cholestyramine, which kind of gives some validity to the potential mechanism of action of how this is happening based on the use of cholestyramine and bile acid buildup. So it is very rare. I've only seen it a handful of times, but the patients are miserable when it's happening. So we try to take care of it quickly so they don't discontinue therapy and can complete the full course of the MAVERIT. The elevated bilirubin that's listed on here, usually what we see as far as that goes with this is pretty normal in most patients, even non-cirrhotic patients, where you see a little bump in their bilirubin, but we're talking more of the greater than 2 limits of, or greater than 2 times upper limit of normal that sometimes is worrisome. The good news is that usually these aren't associated, this elevation is not associated with symptoms. And usually resolves on its own. So we just say to monitor it. If the patient starts complaining about having other symptoms, then you worry, but usually it resolves on its own and isn't something to be super concerned about. And lastly, the diarrhea. I always like to highlight with patients that the diarrhea we see with MAVERIT is really more like a softer than normal stool. So I don't like patients to think that having frank watery diarrhea is normal and it's from the MAVERIT, because then I'm concerned that it's more of like an infectious or some other type of diarrhea going on there, because I don't usually expect patients to be run into the bathroom when they're taking MAVERIT. But your normal, stay hydrated, dietary fiber, that sort of stuff as far as recommendations. And that's all I have for MAVERIT. For Epclusa, kind of the same stuff here. Pretty well tolerated. Headache, fatigue, and nausea are pretty common with the same sort of recommendations that you saw on the MAVERIT slide. But with Epclusa, something that is actually seen more common, at least I see it more common in these sofosbuvir-containing regimens, is the insomnia and the irritability. So this is going to be sort of the same information that's on the Harvoni slide next. So what we usually see is that small percentage of patients where they can't sleep. And most patients, when they tell me that, they can fall asleep okay, but then they wake up in the middle of the night and can't go back to sleep. It's that sort of presentation that they have with the insomnia. So you've got your, run of the mill, normal, avoid caffeine, don't eat too close to bedtime kind of stuff. They can try over-the-counter diphenhydramine and melatonin. That's usually the first way that I go as far as trying to help them to get some sleep. But something that I always recommend to them is to change their administration time. So if they're taking Epclusa right before they go to bed and they can't sleep, maybe try taking it in the morning. That way they're awake during that time and more exhausted, normal bedtime, and then the Epclusa is not having that interference. So just adjust that time. On the flip side, though, when they have irritability, so you've got your recommendations here, but I also try to see when their admin time is. When are they taking it? So if they're really irritable, maybe take it at night. That way you sleep through the irritability and then can get up rested and not feel irritable in the morning, sleep through that side effect. So that's Epclusa. Pretty much the same thing. Same story here with Harvoni. So I won't touch on any of those for the sake of time, but the last one here that I have on here is the Zepatier. So with this one, again, pretty well tolerated with your headache and fatigue. The only rare one that I've seen occasionally is going to be the increase in ALT, where they get pretty high. Again, similar to what we talked about with the bilirubin with MAVERIT, usually it is transient and resolves within a couple of weeks. The interesting thing here is we don't usually see it until towards the end of treatment. So Zepatier is a 12-week treatment. So our recommendation here is just to monitor it at that 8 to 10-week mark. And then once they finish, just to make sure that they normalize. But unless they have symptoms or something else that comes along, then usually there's nothing to do because patients are asymptomatic and it goes away. So that's really all I have, which is why I said this is probably not going to be super long. So I did some digging just to see if any of the different databases had anything different in them, some of the post-marketing stuff that we've seen. So I couldn't find anything through the FDA's website that was really riveting or life-changing. So what I have on here is the WHO's database, the VIGI-base or VIGA-base, depending on whether you prefer hard or soft G's. So there was actually a study that was put out a couple years ago where they looked at the data in this database from 2013 to 2020 and tried to evaluate, is there any differences between what we see in the clinical trials and what's happening in the real world? So most of the reporting that happens in this database, at least for this study, was coming from the US and Canada, and they included all the regimens that I have on the list here. I crossed out the ones that are not on the market or not recommended anymore. And they also excluded reports of anything that included ribavirin, interferon, or things that were already off the market that we haven't used in a long time, like telaprevir, boceprevir, those agents. So those were all automatically excluded. So what they found is that most of what's reported in that WHO database is consistent with what you see in the clinical trials with your headache, GI stuff, fatigue. They did see some interesting upticks in cardiovascular and pulmonary adverse events, but also recognize that this is limited to a database. So you're kind of subject to database bias of the reporter. You don't have your full patient characteristics to be able to compare them. They're on different regimens, those sort of things, as well as, Harvoni looks the worst because it's also been on the market the longest. Now, I wouldn't say that I think that the percentages that were presented here as far as the outcomes were really riveting, but it's always worth taking a second look into something to see if that signaling could pan out to be anything. So, maybe we'll see some studies come out, but there's nothing really to write home about. Some of those cardiovascular events were like MIs and cardiac arrest. The pulmonary indications were things like dyspnea, respiratory failure, and pneumonia. So something to follow, but I don't see anything in there that was really alarming to me as far as, concern for specific patient populations or changing of practice. So overall, the take home is that DAAs are, and compared to what we used to have 10 plus years ago, really well tolerated. So most patients don't have a lot of side effects. So long as we're screening and monitoring, usually we have mitigation strategies that can help overcome them. Specifically in those patients that have diabetes and hepatitis B, making sure we're screening and looking at those that have decompensated patients and getting them the right treatment. For completeness, this is where you can report. I love reporting side effects, especially for new drugs, just because I like to, make sure that everybody gets all that information and the stuff that we're seeing, whether it's expected or not. So I always encourage reporting, although it is tedious, but it helps us to find things like hepatitis B reactivation with direct-acting antivirals. So at this time, what I would really like to do is turn it over to you guys and you tell me what questions that you have or what side effects you're seeing or anything weird that you wanted to talk about.